Is Dr. Kochi with us?
Maybe he'll join on the way.
Okay, so we can just start ahead. Okay. Thank you everyone for joining in. Welcome to our weekly Let's Talk weekly webinar of Let's Talk COVID series. And today we are going to talk about obstetric anesthesia consideration in COVID-19 patients. And special thank you to our speakers, Eric Basara and Joyce Murezi. And on the panelist side, we'll have Dr. Kochi will be joining us, and Jude and I. So we are going to start off, and I'm handing over the session to Eric as our first presenter. We have 1 hour, so each one of you have 20 minutes. Let's start.
Thank you very much, Markton. Good afternoon, friends and colleagues. My name is Eric Basara. I'm a practicing KRNA at the Kilifi Hospital. Together with Joyce Kinano, who is a KRNA tutor at KMTC, Kisumu, we will be presenting a talk on anesthesia considerations for COVID-19 obstetric positive patients. We will touch on the extent and the spread of the disease. Next slide, please. We will touch on the extent and spread of the pandemic, infection, transmission, and its implications in to the clinicians, management of a COVID-19 parturient for labor analgesia, elective section, and also emergency section. At this point, I just want to note the following. Hospital practices and resources may vary a lot. Some of the facts that may be relevant to a given ideal situation. We just present what is ideal, but may not be applicable in some or even in most of the cases, institutions that you're practicing. Again, literature as regards to COVID-19 disease is changing. There's so much that we don't know about this disease, and it is changing at a very rapid pace. What we present today may not be relevant in a coming week. So we need to keep on updating ourselves. At the end of the session, we will have a Q&A session, and we will be joined by Dr. Alan Koch, a friend of this chapter and an anesthesiologist practicing at the Coast General Hospital, and our colleague Joe Domas, who is also a KRNA tutor. Next slide, please. The first case of COVID, let me just introduce the whole issue again. We are talking about an obstetric patient, COVID positive. However, it is important that we keep on reminding ourselves about the disease and learn the latest information concerning this disease. So the first case was reported in China in December 2019. WHO declared it a pandemic in March 2020. Within 3 months, 8 million people spread over 188 countries were infected. So there is hardly any country in the globe that has not been affected by this disease. Today, over 21 million people have been affected with 760,000 fatalities. 90,000 healthcare workers worldwide have been affected. In our country, it has spread to almost all counties with over 30,000 cases and more than 500 fatalities. More than 300 healthcare workers, which represents around 10% of the people affected in this country, have been infected by this disease with several fatalities. What is the causes for the rapid progression of this disease? It has a long incubation period of 2 to 14 days. However, the moment you get infected, within 2 days, you start shedding the virus and infecting the people who are around you. It has this long incubation period is detrimental because you cannot be able to test everybody every time. And within the 2 days, normally they are mild and non-symptomatic. and you will not know that they're actually shedding the disease. There can also be some asymptomatic carriers. These are people who have been exposed to the disease and they're shedding the disease, but they're not having any symptoms at all. And they may be shedding this disease to others who might not know that they're either diseased or infected. This disease has a very low minimum effective dose. Just a few hundred virions are enough to make the host develop this disease. It has a higher and it has an early and higher viral load in the upper respiratory tract. So the initial presentation is actually flu-like symptoms. These flu-like symptoms cause the infected person to cough and sneeze, and in the process of doing so, they release these particles into the environment, into surfaces that end up spreading the disease. Compared to the other other coronavirus, SARS-CoV-1, this SARS-CoV-2, which causes COVID-19 disease, has 10 to 20 times more affinity to the receptors to the receptors in the body. This means that this the reason why it has a rapid progression is because, as compared to the SARS-CoV-1, this particular disease is more virulent than SARS-CoV-1. Continue. Next, please. What is the mode of transmission? I want to note that there is the droplet particles which are more than 5 to 10 microns in diameter. These ones are termed as heavy. Coughing and sneezing, when somebody gets infected and the patient starts coughing and sneezing, these small droplets can be, when they reach the oral nasal mucosa or the conjunctiva of a person, they can easily the person can actually get infected. It is a heavy droplet when they're more than 5 or to 10 microns, so it falls within a radius of around 2 meters. So it cannot go beyond 2 meters. Again, if an infected person sneezes or coughs, these droplets can land on surfaces nearby, like the regular operation table or the table that you're actually eating, and somebody else can touch that table and touch the face, and you end up going to the oral mucosa and cause the disease again. This disease can also be airborne or aerosol. Experiments have been carried out in a lab controlled situation where droplets less than 5 microns in diameter, these are very, very small, have been injected into this room, and then samples from this room have been taken, and they've been found to be remain suspended in the air as mist. And these droplets are viable up to 3 hours. However, these are just lab settings. Other tests they have tried to sample more infected areas like the ICU, where there are so many aerosol generating procedures. They've tried to sample this air to see if these droplet nuclei are available, but there is more to be done to know whether it's actually airborne transmitted. However, for us healthcare workers, we have to be very careful. These small nuclei, less than 5 microns, travel longer distance, and the truth of the matter is that they can be generated in our clinical settings in the things that we do every day. What are the aerosol generating procedures that we normally carry out in our day-to-day clinical practice? Endotracheal intubation and extubation, bronchoscopy, open suctioning and nebulization. All these are aerosol generating procedures. Bag mask ventilation. Bag mask ventilation means that when you're bagging the patient, there's some air that leaks from the airway, and when you are nearby, this air can actually carry aerosol. especially the ones that are 5 microns and below, and can cause infection to a person standing nearby. Disconnecting a patient from a ventilator, especially when the ventilator is on and it's pumping, it is very, very easy because it's under high pressure, especially from the lungs, and it's very easy to release air into the environment and release these aerosols. Non-invasive positive pressure ventilation, it means this kind of ventilation uses high pressure, and being non-invasive, it does not cause a high 100% seal, and that means there's going to be leakages of air that is released into the atmosphere and can easily infect a person standing nearby. Or these aerosols can also land in surfaces and spread the infection to other healthcare workers. Tracheostomy is also one of the aerosol generating procedures, and cardiopulmonary resuscitation. What do we do to prevent ourselves? Because the reason why we are talking about this is because of the high number. Worldwide, we know that healthcare workers are 10% of the people who are getting affected are healthcare workers. So the idea of talking about COVID-19 is that we always feel sad when we know that there is a person, a colleague, a family member who has been infected by COVID-19, especially if it's coming from the workplace. So we need to take care of ourselves. How do we do that? We need to have to whenever we know that we are working in a place that is that is a high prevalence of COVID-19. We need to, especially in the clinical areas, we need to have a well-fitted N95 mask with fluid-resistant or a fluid-resistant surgical mask. We need to have a surgical cape or hat. We need to wear goggles or eye shields. We need to have a fluid-resistant gown or coverall, and also cover our shoes, cover our shoes with shoe covers, and wear two pairs of gloves, the outer one being sterile. The pregnant parturient patient and COVID-19. How does this patient, this is the main talk today, how does this patient present to us? The current situation is that we are moving on as if it's business as usual, yet the COVID-19 is in our communities. When patients come to the labor ward, they have not been tested. They just come in and go into normal labor as if nothing is happening. Yet this disease is in our community. How do they present? They can come with fever, or they can come with mild, severe, or even critical condition. These mothers, so they can have mild fever, cough, general flu-like symptoms. These are simple things that they normally come with. They can also have gastrointestinal manifestation like diarrhea, vomiting, abdominal pains, even in the absence of respiratory symptoms. It's important to note that these symptoms are non-specific, and maybe sometimes when they present themselves, they may be attributed to the pregnancy and labor. You know, people who are pregnant, they come with all sorts of complaints. I'm having a headache, I'm having diarrhea, I've been vomiting since I started this pregnancy. So sometimes these ones are covered. These symptoms of COVID-19 are covered by the non-specific symptoms of pregnancy and labor. Early data indicates that this data is coming from China, that COVID-19 pregnant women, only 8% develop severe symptoms, and only 1% need ICU care, compared to the general population of 14% who develop severe symptoms. These are 14% are non-pregnant, and 6% who need ICU care. Basically, what the studies are showing is that COVID-19 is a mild disease in pregnancy. When a patient presents, the ideal way of looking at it is that all patients who are coming in labor room ideally should have a rapid test so that they are known whether they are positive or negative. The moment one is known that the patient is having a COVID-19, A multidisciplinary team should be formed involving the obstetrician, the pediatrician, or neonatologist, and the anesthetist. We know that anesthetists get involved from the moment go, especially for COVID-19 patients, because we are involved in many things that are going to, in the following slides, you'll see that are contributing to the care of this patient from the moment the patient arrives in the patient clinic coming to labor room. The patients arriving in the hospital should be screened for COVID-19. Do we have a rapid test where we can screen and actually have the results right there, that this patient is actually positive or negative? What we're having right now is you do a test today, you are going to wait for 2 or 3 days to get the results. A woman in labor does not have 2 or 3 days to wait. So what do we do about this? These are challenges that we are facing. I'm sure you are facing the same challenge that I'm facing. We don't have a rapid test kit that can actually do a test and give the results right there and say this patient is, pregnant woman is actually COVID-19 positive or COVID-19 negative before the patient goes into the labor room. What is happening in other institutions is sometimes we have heard in the news where literally a big percentage of a hospital is closed because maybe only one patient spread the disease to very many healthcare workers. So how do we handle these patients? A COVID negative patient goes to a usual labor room or to the ward, and the obstetric staff and normal obstetric staff and facility, they take care of normal labor and delivery. Nothing that needs to be, just the things that we do every day. However, if we have a symptomatic carrier, a patient who is a COVID suspect, a symptomatic carrier is a patient who is COVID positive but has no symptoms. A COVID suspect is a patient who may have come from a country or a place that has a lot of prevalence of COVID-19. These are suspect, or maybe has had a contact with a person who is COVID-19. So a symptomatic carrier, a COVID suspect, and a COVID positive patients all are treated the same way. A fitting N95 mask must be given to this patient, and the patient is transferred to a COVID facility, an area, or an isolation room within the same facility. Preferably, if that room is going to be used for COVID-19, for COVID patient, that room should be a negative pressure room with 6 to 12 air exchanges per hour. When I talk about this, I am reminded about where I work myself, and I know I use air conditioning. I don't know whether there's any other person who doesn't use air conditioning, and I don't know how many of you are actually having a negative pressure room that has 6 to 12 air exchanges. These are challenges that we face every day. If we get a COVID-19 patient in that room, in the operating room that we have, in the laboring rooms that we are having, that are having air conditioning, actually the air comes from outside and is pumped into the room in a form of a fan. I don't know how safe we are. However, neuroaxial analgesia and anesthesia is known to be a non-aerosol generating procedure. However, all healthcare workers performing this procedure should wear full PPEs for these patients. The management, general management, as we look at it, from the moment the patient comes into the labor room, all the way to the time that baby is delivered, we know that the anesthetist is going to be involved in either labor analgesia or a subarachnoid block or combined spinal epidural until the baby is delivered. Epidural anesthesia in early labor should be encouraged. And the reason is because this decreases aerosol generation during forceful exhalation in labor. We know that women in labor can decide either to keep quiet and deliver normally, or they can actually go all the way out and shout and cry and have forceful exhalation in labor. This one increases aerosol generation in terms of droplet and also nuclei into the atmosphere. So by having a labor analgesia, it reduces the need for GA, because we have already anticipated that the patient is going into labor. If she goes into labor, she can either have normal labor Or she can also go to a complication and go to have a lower segment cesarean section, or can even have an emergency like a APH, where we need to rush the patient to theater. So having labor analgesia, that is having an epidural in to give a painless labor, it helps this, it anticipates GA or going to theater much earlier, because the conversion time from labor analgesia to operative analgesia is less than 5 minutes. So epidural labor analgesia is considered a non-aerosol generating procedure. It is performed in isolation, in an isolation room or a designated OT or operating room, preferably negative pressure. It is important that these patients have a baseline platelet count. It is known that patients who are COVID positive have problem with platelets, and they have reduced platelets as much as up to 100,000 platelets. And again, vertical transmission is minimal to non-existent in this population of patients. Labor analgesia, it is done in isolation room. All the healthcare workers should don outside the room, not inside. Basically, preparation should be done earlier, and donning should be done outside the room. The number of personnel in the room are limited, and the most experienced anesthetist should do the block. The most experienced, not the senior most. The most experienced anesthetist should do the block. Again, the equipment should not be crowded inside the room. Only necessary equipment should be in the room, including the drugs. Everything else should be prepared outside, and only what is needed should go into the room. The dosing as for labor analgesia is different to the general population. We want to dose at 0.0625% of bupivacaine, so that the patient can walk around and just have painless labor. But in this case, you just want to make sure that the analgesia takes effect immediately. So instead of 0.0625, we use 0.1%, and you can add adjuvants like fentanyl to enhance the density of the block. Donning is not as important as doping. Doping is known to be the weaker link in donning and doping. This is where infection takes place. So it's important that doping is carefully done under supervision in a designated area. What are the indications for cesarean delivery? COVID-19 is not an indication for cesarean delivery. It is important that the threshold to make a decision whether to do a cesarean or not to do a cesarean is going to be lower in COVID-19, because there's going to be a lot of preparation before you actually do the cesarean section. The threshold should be lower, and that means decision making is going to be much earlier than in the general population. The choice of anesthetic technique, it can be either general or neuroaxial. Anesthetic technique must be individualized for every particular patient. This one is not going to be like general for every patient, but this patient must be assessed the same way that we assess every patient, and the needs are met as necessary. So some of the things that are going to be looked at are the anesthetic, obstetric, and fetal risk factors, patient preferences, and judgment of the anesthetist. This is very important. You make a decision early. Key decision making is based on the presence of maternal or fetal compromise. That is when you make a decision to do a cesarean section or not. So you should consider the benefits of neuroaxial versus GA in relation to COVID-19 disease pathology. COVID-19 disease is a respiratory system disease. Respiratory changes in pregnancy, e.g. FRC and oxygen demand, are different from the general population. 20% in pregnancy and 100% in labor. And in COVID-19, there's associated pneumonia, increased risk of obstetric and anesthesia morbidities. So just like in the general population, when these patients get intubated and for a cesarean section, not necessarily for COVID-19, they tend to deteriorate very fast, and they tend to have more fatalities as compared to if a neuroaxial anesthesia is done. For elective lower segment cesarean section, and the anesthesia of choice in neuroaxial technique. At this point, after this slide, I will tell Joyce to continue with the rest of the presentation. So let me just finish this slide. Joyce, just be prepared to take over from the next slide. Anesthesia of choice for elective neuroaxial is neuroaxial technique, subarachnoid block, or combined spinal epidural, unless contraindicated. What are the contraindications? Patient refusal is one of them. Thrombocytopenia is one of them. Infection of the site, and many, many others. What are the concerns when you are thinking about a subarachnoid block? Thrombocytopenia has been reported with these patients. Platelets of 100,000, even low, with mild parturients, low accounts even with more severe cases. It is safe to perform neuroaxial procedures up to counts of 70,000, and it's up to you to make a decision. In fact, some of lower than 70,000 platelets. Sometimes you make a decision and continue with a subarachnoid block as compared to giving the patient GA. All COVID positive patients should have a platelet count on admission. That means you don't need to wait until the decision has been made to go for a cesarean section. That is when that you are looking for the platelets. The platelets, the patient should be investigated at the moment of interest into the admission room. Joyce, are you ready?
Mute.
Yes.
Yes. So thank you, Eric, and welcome, Joyce. And to our participants, kindly write your questions at the question and answer segment. We will respond to them towards the end of this webinar. Thank you. Joyce, you can proceed.
Thank you, Macton. So hi, everyone. So I'll continue from where Eric has left. So let's continue. So for emergency cesarean section, remember, just like Eric said, this patient is not coming for the cesarean because of the COVID status or the COVID suspected status. They are coming because they need because of the CS. So there are other underlying reasons as to why they are coming for the CS. So the COVID-19 is just like a coexisting disease. Okay, so we should always remember that this is a parturient patient. The way we handle this, every other parturient patient, taking into consideration their changes, both anatomical and physiologic during pregnancy, then we should always remember that now on top of the COVID disease. So from the time the decision is made to deliver this patient, who is an emergency patient, then ideally it should take about 30 minutes. But sometimes, and especially due to the challenges that we may have in our different facilities, this may be delayed for preparation. You see, maybe getting the gowns, the masks, getting the personnel, because like we've been told by Eric, is that we need very minimal personnel into the operating theater. So this may take a little longer, but we should aim at maintaining the standards of within 30 minutes that this emergency cesarean section is done. So patients should be involved, and this is done at the time of signing the consent. Let the patient know what to expect in the delivery room. Of course, now because you'll be gowned, you have the mask, you have the cape, you have the face shield. She should know, so that she knows she's not going to see your face, so that she's prepared psychologically for what she's going to see. So if the subarachnoid block is recommended, then this should be based on the indication. Why are we doing this cesarean section? You see, as much as you're saying that the subarachnoid block or the neuroaxial anesthesia is better, then the bottom factor, or the determining key factor is what is the indication for this cesarean delivery. There are emergencies, remember, for example, severe hypovolemia, then GA will take priority. And also remember that PPE is important for everyone else. Next slide. So if it is GA, should be done in a negative pressure operating theater. All members should have full PPEs. That means every person who is getting into that OR, the medical personnel should have full PPE gear. Minimum number of people. Even the runner nurse should be out so that she's sent for anything that is needed, so that she doesn't keep going out, in and out. And it's also going to help in reducing the number of personnel inside the operating theater. HME should be applied between the breathing circuit and the face mask. So it is important for us to have the HME because it's, apart from it being a standard practice, then it also it is more, you should consider it more because it protects the machine from the patient's microbes, whatever the patient breathes out, protects it from infecting the anesthesia machine. Next slide. So we're still on the general anesthesia for this cesarean section. You use low flow rates of oxygen when you're oxygenating the patient. Remember, this is a patient who has a respiratory morbidity. So the low flows are going to use low flows and oxygenate for a longer period of time to enhance or to give you time for more denitrogenization. Then, of course, this is a general anesthetic, so the standards are maintained. You need a rapid sequence induction, avoid bag mask ventilation, full dose of muscle relaxant. You need to relax this patient. Then you consider using a video laryngoscopy so that you're not bending when you're doing the normal laryngoscopy, so that you're not so close to the patient's face, so that you avoid breathing in the whatever aerosols that this patient produces. Then precaution also should be taken into great consideration during extubation. The same way, we should not bend so close to the patient. Remember the aerosol producing procedures that Eric has talked about in the earlier slides. So one of them is the suctioning and extubation. So we need to take precautions when you're extubating this patient. And to conclude all what we've said, what Eric and I have said is that we should note that hospitals have different practices, different resources, different SOPs. So depending on what we already know about COVID-19 patients and obstetrics, then we should adhere and use the knowledge that we have, plus the frequently or rapidly changing literature about this disease, so that we're able to take care of this patient. COVID-19, the disease is changing every day. We have new guidelines almost every other day. Probably what we have said today is not going to be in use tomorrow. We are going to have new guidelines. So we need to prepare ourselves, or we need to be ready to adapt and change to these guidelines so that we protect ourselves and we also protect other healthcare workers and protect the populations where we live. Thank you. Back to you, Markton.
All right, thank you, Joyce. And now we are going to go to our question and answer segment. And the first question that I want to present to our panelists is one by S.R. Chemutai, and he has kindly clarified whether the use of intramuscular morphine in pain management in obstetric patient is appropriate, considering its effect on respiratory system, so to COVID-19. So one of our panelists can respond to that. Eric?
In my opinion, COVID-19 should not be a reason why we should deny our patients pain relief. One of the reasons why patients come to us is because of pain. we must relieve this pain. The incidence of respiratory depression because of morphine is questionable, especially concerning COVID-19. Even these patients, they need pain relief. So in my opinion, we should not deny our patients pain relief because of COVID-19.
Macton, maybe I could add to that and
Thank you,
say
Eric.
that,
Anything?
yes, I would say that, remember, intrathecal morphine it does not routinely cause respiratory depression. If we do the right doses, then we do not expect respiratory depression for this patient. And also, we should have in mind, if you give it, then you know what to watch for this patient who is already having respiratory symptoms for the COVID-19 disease. Thank you.
Just to add on that, Macton, COVID-19, again, according to the current information that is available on the net, it's a mild disease in pregnancy. So these patients, the chances of getting a severe COVID-19 complications in these patients is quite low, and as low as 1%. So giving morphine should not be held back. Macton.
All right. Okay. Thank you very much, Eric. And we have another question from Jamal. Jamal is asking kindly, how do we go about or ensure negative room pressure of 6 to 12? Or I think Eric tried to talk about this. Kindly something, Eric.
I want to ask everybody in the if you have a negative pressure room in your institution, raise your hands. Most of us are working in areas where we're just using air conditions. We are not using negative negative room operating rooms. And honestly speaking, I'm not an architect, or I don't know how to construct a negative pressure room. But the idea is the extraction of the air should be from above. So the air is extracted. There are some extractors that filter the air that goes out, and the room, the air moves from inside, from outside coming in, but not from up going out through the doors. But how to construct it, honestly speaking, I don't know.
Yeah, totally agree. This is a challenge to most of our workplace. Joyce, anything to add?
Macton?
Yes, Jude. Jude, could you respond or add something on top of that?
Yeah, I think as you are doing the construction of the theaters,
yes,
most of the time the biomeds are involved in the drawing of the structures and how the theaters should look like. A good number of modern theaters usually have extractors. That is a system that ensures that the air within the room is moved out of the room. Okay? And that is how the COVID wards are also structured. There is usually an extractor that pulls air from the room and takes it out of the room. Usually, just like Erica said, is usually pressed above, on the top, on the upper side of the room. So basically, you need one extractor per room. It will be able to ensure that the flow within the room is ensured. Basically ensuring that whatever is produced in the room actually goes out, as opposed to the AC, which actually brings air into the room and makes it even more stuffy. You see that? So basically it is an extractor, sort of. Okay? Yeah.
Okay. I think that should be the deal, but most of the challenges that we have in our setup is that most of the theaters, these were not put into consideration, and structural modification in some of these theaters are not possible. So it becomes difficult even to make any adjustment to meet our current pandemic condition.
Yeah, that is very true. But a good number of our theaters can still be modified. like the one at JTRH, I think a good number of them can still be modified, although there is still a lot of issues. The ones in Kisi have extractors and the ACs. So I've looked at quite a number of theaters, and I can see that a good number of them can be modified to be able to ensure that there is negative pressure in the rooms. We just need to involve the biomeds. They'll be able to do that. That is their function. We don't have to bother much about that.
Markton, the unfortunate thing about construction of operating rooms is that the decision to construct an operating room is made outside without any of us knowing. By the time we realize, we are told that there's an operating room that has already been developed and you just go and occupy. We, the users, are not involved. And by not getting involved means that by the time you go into this room, there's so many things that are not in order. They are not in the right place, and you want to change them, but by that time it's a bit late because there's so much that they have been put in the construction of the operating room. Maybe this is something that we need to look into as anesthetists and pray, as nurses and anesthetists, and pray that in future, when there is a construction of this nature, we get involved in the initial planning of the theater and what we want from it. For instance, if we never knew about COVID-19 that is going to come up, and then suddenly we have it. If we were involved from the word go, and this is the way a normal operating room is supposed to be constructed, we will not be going back to modify anything. We will be just continuing the same things that we do. Every theater was constructed the same way. I'm hoping that in future, the decision makers are going to involve more of the stakeholders and the users of the operating rooms in their planning before they construct the theater.
All right. Okay, thank you, Eric. And we have another question. In case of a suspected COVID-19 pregnant mother who is having an unreassuring fetal condition and goes for a C-section, should we treat the infant as a COVID suspect patient? Joyce?
Okay, Markton.
Okay. Jude, then Joyce.
Okay, Joyce,
Okay, Jude.
Joyce, go ahead.
Okay. In my opinion, I don't think this neonate is a COVID positive patient or a suspected COVID. Because so whatever is the reason for the non-reassuring fetal status is not the COVID. The patient is not COVID positive or does not have the COVID disease, because there is no literature that has shown that a COVID disease can be transmitted from the mother to the baby in utero. Yeah. Markton.
Thank you. Thank you for that, Jude.
If I may add, if I may add, COVID has not been shown to cross the placental barrier, and therefore babies born of COVID mothers are usually not COVID infected. A study in Italy has shown that they actually are COVID free. Okay, so the babies born of COVID mothers are not COVID infected. On the same note, the COVID virus is not transmitted through breast milk. So it is still safe for a COVID mother to breastfeed her baby for as long as she has a mask that is safe to keep the baby safe. The baby can still breastfeed and doesn't get COVID. Okay? Yeah, those are studies from Italy and the UK. They showed that.
Just to add on that, the moment the baby is delivered, the baby is the procedure is to separate the mother and the baby immediately while the mother is still active. But whenever there is need for breastfeeding, the baby is taken back to the mother to breastfeed and then back to the nursery again.
Thank you. And probably this is our last question. Shinyonga Dixon is asking, many times we do not have N95 masks, but surgical masks are available. For instance, I did a case which needed intubation with only a surgical mask. That very day, we had 3 patients turning positive in the hospital, and we lost 1 after 2 days. Should I treat all procedures that are aerosol generating activities as COVID, or only confirmed cases?
It's very important as healthcare workers to know that PPE is also expensive, and the need to use is the one that determines how to don or to doff, or how to don, basically which PPEs to be used where. If we are going to say that we assume that every aerosol generating procedure is COVID positive, that means we have to don and fully, which is actually not possible. But the precautions that we need to take all the time is to make sure that if you wear a surgical mask that actually protects you by more than 95%, you need to have it well-fitting. The procedure for intubation, you want to do a rapid sequence induction because you want to spend as little time on the face of the patient as possible. When you're inserting the endotracheal tube, the bacterial filter should be on top of the endotracheal tube. You don't put it into the patient and all the aerosols come out from the patient right into your face. You want to make sure that whatever is coming out from the endotracheal tube after intubation is actually filtered, only for you, not only for you, but also for your assistant. Make it a habit to assume that every time that you are intubating a patient, you are suspicious of this patient. When you are suspicious, you go an extra mile to take a bit of more precautions that normally you would not have done so if it was just the normal routine work that we normally do. We are living in different times. So do something else. Wear a gown, for instance. Wear goggles. Make sure that before you intubate a patient, make sure that your mask is actually well-fitting, even if it's not an N95 mask. Make sure that it's actually well-fitting. And if N95 masks are available, please ask for them. Don't shy away from this. If N95 masks are available, ask for them. If goggles are there, ask for them. If disposable gowns are there, ask for them. Use them as much as you can. But by assuming that you can only know after a few days that the patient intubated was actually COVID positive and you have not taken any precaution, actually we are exposing ourselves. So we need to take a bit more precaution as compared to the way we used to do intubations before. We need to go an extra mile to protect ourselves. It's not about our patients, it's about us now.
Thank you. Joyce?
If I may add on the same, I think this question has come up a few times. Probably this is the 3rd time it's coming up. And we've always talked about the precautions you need to take before intubating any patient. And we said you need to protect yourself, wear at least a gown. You need an N95 mask. We are not asking for anything less than an N95 mask for all our procedures. And that is why you saw the health workers, they're called the Health Professionals Forum, calling for a strike over the protection of health workers, because the government is taking us for a ride. We are exposed, and when we tell them that we're exposed, they're not really taking anything seriously. And therefore, we need to demand for this, that we need to have an N95 mask on anytime we are doing a procedure, okay? And then you need a face shield, okay? Either goggles or a face shield, transparent face shield on always as you intubate any patient. Treat all patients that come to you as COVID positive unless proven otherwise. That is the only way we'll have the rest of us, all of us available when this whole thing is gone. Okay? Yeah.
All right. Thank you, Jude. I did not see any more question from our participants.
Macton, there's one question I've seen flash through my screen, and I got concerned about the question.
Mm-hmm.
Maybe if you can look at it, it's asking. Someone was asking hospitals that have one breathing circuit for all their patients, or something like that.
Just go ahead and read it because I can't see it.
Okay, let me get it.
It's on the chat.
Let me read it through.
Okay.
Yeah, it says, how many government hospitals have one circuit?
Yes.
For adults and pediatrics, no HMEs. In such a situation, any input, please?
Yes, that's the question.
Yes, I want to say that if there is any hospital currently that does not stock enough circuits and does not have HMEs available for the surgical patients, I don't think that hospital needs to be doing any cases, because you are basically exposing your patients to COVID-19. You're going to have these aerosols going into the absorbent and all that. You're not going to change that circuit. The next patient comes in, you're going to infect them, you know. So I don't think that theater needs to be running, honestly. I don't know what the other guys think.
It's easier said than done. I don't know. I can't put myself in a position like my colleague, the person who has asked that question. It's a difficult situation. Even when there are no extra circuits and HMEs, and a mother comes who is just about to rupture, naturally, Jude, you'll just go and save this mother instead of leaving that mother to die. It's a sad situation, but that is a policy issue. Sometimes as practitioners play very little role. We just keep on talking, but nothing. People don't do much. But it's important that you stand your feet and talk to the theater users in that particular hospital and say that our standards are this low. We are endangering our people. These are your people. These are my people. We are endangering them. We need to talk. Sometimes even saying that we will not operate until we know whether we are going to get these things or not. But it needs a combined effort. It is not an individual effort. It needs a whole theater team effort to say, these are the standards that we want. You start talking. You don't keep quiet about this thing. You start talking. Nobody can talk for you apart the person who is actually in that operating room. And it's not you alone. You must get forces from the theater in charge, from the surgeons who operate in that room, from the other anesthetists. All of you talk in one voice, and you know that you'll get something done.
Okay, maybe just to add to what Jude and Erica have said about that is that I always like looking at the operating theaters that I've worked into or that I walk into as if I was the patient and not the anesthesia provider. And that way, it makes me responsible. It gives me the responsibility of being my patient's advocate. What that means is that today I am the anesthesia provider, and in the next 1 or 2 minutes, I could be the patient. And if I'm working in a theater whereby the breathing circuit is one, then it's the same breathing circuit I'm going to be to have if I need it. So we need to be our patient's advocate for these things, despite the environments that we work in. Some of these things are basic standards that can be maintained if we know how to ask for them, if we use the right channels to ask for them. and we should not tire to ask for them. You can ask for the one thing even 10 times before you get it. I know those of us who work in government facilities or in low resource settings, we know that you could be asking for something worthy maybe $1, 100 Kenya shillings for 10 times, but you still get it. So depends with how you ask for it and which channels do you use to ask for it. So let's be our patients' advocates.
Thank you, Joyce. We need to be persistent and take care of our patients. It's already 8. Maybe last comment. We want to close. Eric,
yeah, before you close.
Yes.
I want to believe that all our med soups are as reasonable as we are. Because when I was recently moved to another facility, and when I got there, there are no HMEs, and I just told the med soup, kindly give me a HME to work with. If there is none, then just close the theater, because I'm not going to expose my patients. Okay, let's be the patient's advocate, just as Joyce is saying. Let's be the patient's advocate. We cannot say that now that this mother is coming with APH, and I know a patient has left theater whom I didn't know their positive or negative status, used the same circuit. We want to put this mother on the same circuit. Why can't we refer to the next facility? Okay, referral is still a form of management. Okay, so let's not just expose our patients just because we are limited. Can we advocate for our patients?
Thank you, Jude. Thank you, Jude. Before we close, I can see the chairman is with us. Samson, 1 minute closing remark, please. Samson, 1 minute for you.
Thank you very much, team. My name is Samson, the chairman, KRNA. We appreciate the work. Sorry.
Chairman, your internet, I think the sound is not very clear, so we can't get you very well.
So can you hear me now?
Not yet. Try again.
Yeah, I'm saying Mamato and the team, we are progressing very well with God for you.
Still not very well.
Samson, pass.
Yes, Mato.
Can't communicate.
Sorry, Samson, you are breaking away. We really can't get you well.
Hello.
Still not very good. Okay. One last trial.
Try.
I don't. Can you hear me, Mato?
Okay, say something.
Yeah, I'm saying thank you guys for the work we are doing. We appreciate. We also welcome our visitors on the program. And chairperson, our visitors on our webinar from other countries. We appreciate.
Eric, I'm sorry, you just have to write it for us. We can't get you very well. The internet is not very good. So maybe write for us special notes where we can read and we can get back to you next time. Otherwise, on behalf of our panelists, thank you very much, presenters Eric and Joyce, for your presentation. It was wonderful having you guys. And of course, Chairman, thank you for joining us. Even though we can't hear you next time, we will. And of course, we can't forget our host, PANAC, that is Pan-African Nurse Anesthetics Conference, and NNAK, and of course, Kenya Registered Nurse Anesthetics Charter. On behalf of everyone, we say thank you, and let's see you again on Friday. And the code was already shared, so go and redeem those points. They expire by 23rd. So I'll end the show by saying thank you, everyone. See you again next week on Friday. Asanteni sana. Bye-bye.
Bye.
Bye.